Hello, welcome to the spine lecture. So we will be going through spine, postural alignment, and strengthening. I'm Emily Norris. You all know. And we'll begin. As we're going through, there's quite a few of these slides that we will actually just be covering in lab because they're really hands-on. So I might stop on them for a second just so you can see, and you can pause the video if you would like to study those before lab. But I will cover them in lab. So palpation is one of those. All the postural deviations are things that we will go through in lab as well, and trying to determine what is tight, what is an appropriate stretch, strengthening, and cueing provided to maintain an erect posture. Also pain associated with those conditions. So we'll cover this slide in lab. So we're going to move on to some of the common conditions that can cause pain in the spine. So first one we'll talk about is a herniated nucleus pulposus. You'll see it abbreviated as HNP, and sometimes it will be referred to as a disc lesion. Herniated disc, some people will call it a slipped disc, which isn't always accurate. A slipped disc is also more accurately referring to spondylolisthesis, but some patients will call it that even if it's just a herniated disc. Seems like there's another word that patients commonly refer to it as that's not medical, but if it comes to me, I'll let you know. So with our herniated nucleus pulposus, that is basically your disc in between the bones of your spine is basically like a jelly donut. So you have two hard bones that it sits in between, and it's like a jelly donut. The center is gel, and then there's kind of a soft, cushiony surrounding all around. And what can happen with repetitive movements that constantly push on one portion of the disc, so repetitive flexion is pretty much the most common, then it will push all the jelly towards part of the donut. If the jelly is just sitting in one area of the donut, we call that a bulging disc. It's kind of ballooned out and pushing some of the disc out, but it's still within the donut. Well, that would be kind of our best case scenario with a disc problem or a disc lesion, because if the jelly's still inside of the donut, it's just kind of scooted over to one side and pushing that side out. Then one thing that we can do is like repeated extension or some other exercises as well, but repeated extension is the thing we focus on in order to level that jelly back out. If it's still all contained within the donut, within the disc itself, then you can repetitively push on one side and level it out. The issue becomes once it actually herniates, once it tears through the outer portion of the disc. So in our jelly donut, it would be the donut itself, and the jelly comes out of the donut. What kind of maneuver can you do to get the jelly back in the donut? I mean, there's nothing you can do and press on the disc to get the jelly back in. That typically is when we require surgery, because now they go in, they clear all the extra jelly, all the extra portion out, and repair the disc so that more doesn't come out. Now there are some, we could do some physical therapy to help the person even if they're not doing, not going the surgical route. And a lot of times they'll have just as good of effects as someone who's not. But we will mention later what some of the symptoms are. It will be in the spinal cord compression in that topic, what some of the symptoms are to look for that would tell you they do need surgery. So we'll talk about that later. But either way, with a herniated nucleus pulposus, the jelly has came out of the donut, so the middle core gel portion of the disc has pushed out and broken through the outer components of the disc. And what you do in treatment is determined by a few things. So we will go through flexion bias and extension bias protocols, but altogether the focus is to increase the disc space decrease the pressure on the disc. So you're trying to decrease the pressure in the part that's constantly pushing the jelly back towards the wrong area and open up the disc space. So if they're constantly in kind of a slouch position trying to do some postural exercises, some traction, things like that, to open up the space so that it's not compressing the disc so much. So core stabilization can help that. Remember, the transverse abdominis is our internal back brace. It connects at the back and goes all the way around. So that is what stabilizes the back. If you get that strong, then it can hold everything together and it can help take some of the pressure off of the discs themselves. So that would be your go-to strengthening. As you know, I love transverse abdominis strengthening. Traction, like lumbar traction, can help open up the space. Stretching, because any tight muscle pulling on the area will add extra pressure and cause it there to be more tension there. So hamstrings is a common one. Psoas is a common tight muscle in this group. Piriformis can be. It usually doesn't put as much pressure on the disc, but it can be. And then quadratus lumborum is the other that is often tight and can irritate the area. You do want to change the ergonomics or the body mechanics that led to the problem in the first place. Maybe it was a power lifter and they were doing it with poor mechanics, or maybe it was someone who has a job where they do repetitive movements and they're either not doing them appropriately or they're not wearing, safety equipment, maybe a support belt or something. So trying to figure out what the cause was and keep from that continuing to happen, even if it's just someone who's constantly slouched in a chair like I am right now. Adding some lumbar support, things like that. Manual therapy, really loosening up everything that's causing extra pressure on that area. So that can often be very effective in pain relief as well. So for a patient who are only comfortable sitting or laying down, we call that a non-weight bearing bias. And aquatic therapy would be ideal so that they're still able to actually be erect, but it helps support the area so there's less pressure if possible. If not, then doing everything in a laying down non-weight bearing position. It's seated, supine, sideline, things like that to decrease their pain. So let's go through the flexion. We'll go through extension bias next. So our herniated nucleus pulposus extension bias. So even though we call it an extension bias, most patients all prefer flexion. This means, even though they'll say, I feel better when I'm slouched, I feel worse when I'm standing straight, if they do, you have them do some repetitive extension. Now they stop just short of their pain. They could do it by laying prone and doing prone press-ups where they're pushing up. This is an example of a prone press-up. Or they could do it in standing. I'll have them put their arms against the wall and let their hips come closer to the wall. And do it usually about 10 times. So after that repetitive extension, if their symptoms begin to centralize, which means coming closer to the back, so less symptoms down the leg, or if they just report that their pain decreased slightly, that it's a little bit more comfortable, or as they're doing it, it's less and less painful each time they're doing it, that would still be under extension bias. Even if the person tells you that they have relief in flexion, it would be the extension bias protocol. So with this bullet point here, flexion appears to relieve symptoms because, so if this is the disc, and typically flexion, so the front of the disc gets closer together and the back part is more open, if it's pushing everything towards the back. So everything's sitting towards the back. I'll use this. This is the gel that's now pushed to the back. If I'm in extension, it's actually pressing on that gel, so it's less comfortable. If I'm in flexion, it's opening up the part of the space that already has more stuff in it, so it's making the problem worse. However, it's relieving the pain by opening up the area. So patients will say that helps their symptoms. But the truth of the matter is it's actually worsening the condition. So that is why we treat it with extension, because over time, if it's pushed itself to the back, it keeps falling off. Then if you can push it to the front by doing repeated extension and get it more in the middle of the disc, then there's no longer that impingement happening and it's less painful. Some of the things that we do is repetitive or prolonged extension. So we talked about prone press up, but another is a prone prop or prone on elbows. POE they abbreviate it as. So you're laying on your stomach and you're propped up on your elbows and you hold it for 2 to 5 minutes. 5 minutes is really hard for somebody to hold it that long, so they may only be able to hold it 30 seconds, but you may want to try and progress to the point of holding it 2 minutes. That would be a prone press up. You could even prop them up on pillows or something if maybe they have shoulder problems. Traction, again, to open up the space. Manual therapy stretching, all the same things that we did just for basic herniated disc, we will do in the extension bias, but all the exercises will go towards extension. Now with the core strengthening, transverse abdominis strengthening, you can still be in a neutral alignment, but you do not want to do repetitive flexion. So you would definitely not want to do crunches where you're repetitively flexing the trunk. Even though people look at that as core strengthening, that's not the type. We don't want to strengthen the rectus abdominis. That is the mobilizer. It's typically more strong anyways, and it does not help stabilize. We want to strengthen the transverse abdominis, which can be more in a neutral alignment, like a plank or the other strengthening techniques we've talked about in class. And then to correct a lateral shift, so sometimes it's pushed to the back. So this is the front of the disc, this is the back of the disc. Sometimes it's just pushed to the back. Sometimes it's actually pushed over to a side. So if it's a lateral shift, then you need to do kind of a side bending motion in order to push that back towards the middle. Of course, I made it fall off. And so this person here is doing that procedure to correct a lateral shift. And how would you know that? You would know it basically by the MRI, the report that the doctor sends with them on their initial eval, and looking at the PT's initial eval to see if there's a lateral shift. And so they could stand with one side towards the wall and shift their hips repetitively towards the wall. So it's kind of like doing the extension. So with extension, you are going away from, like, so that it's protruding out the back and you're moving things anteriorly as you go. So then if it's on the right side, let me think. If it was on the left side, the left is closing right there, the right is opening. So if it was protruding to the left, they would stand with their right arm towards the wall and let their right hip come in towards the wall so that it closes on the left and opens on the right. And then the opposite, if it was protruding out the right side, they would stand with their left arm towards the wall and let their hip fall in towards the wall. All right, so with a flexion bias, this essentially means that it is too painful for them to do the extension. Sometimes they can't even hardly get in a neutral position. Just to stand or lay with their back straight is so painful that you could never get them to prop up on something or to push into extension. Spondylosis or spinal stenosis may cause this. If already there's a narrowing of the spinal column, then there may already be enough pressure that they're not able to stay in that position. So everything would be performed in either a flexed or more of a neutral position. So laying in supine, although it shows a crunch, I still would not recommend repetitive flexion. Like going towards a flexed position, you could do just based on for a stretch and for pain relief and stuff, but primarily if you're able, you're wanting to still do transverse abdominis strengthening and do it more in a supine neutral position. And ideally, you would start with this. If the patient couldn't stand extension, you would start with this. You would start strengthening the transverse abdominis. You could still possibly do traction, but sometimes this is when they would do traction with the knees at a 90-degree angle, with the hips at a 90-degree angle, with the hips bent, versus with the person fully extended. So you could still do that. You could still do some manual therapy techniques. You just may have to change the position, maybe do it in side lying or in seated, or sometimes sitting with leaning forward with their head on a pillow. Then you can still access their back. And eventually, as they improve, then they would get to a point where they could tolerate extension, and you would continue on and progress them towards the extension protocol in order to still help even out that herniated or even a bulging disc. Of course, with spinal stenosis, if whatever is causing that is not ever changed, you may not get towards that goal of getting to the extension bias. All right, so some of the general guidelines, and this is for low back pain or lumbar radiculopathy, herniated disc, and even sciatica. So something I did not mention, I didn't mention a lot about sciatica. I actually wrote a note to add a slide in, and I'm so sorry that I did not do that. So sciatica is just pain all the way down the limb coming from compression on the sciatic nerve. If it stops at the knee, typically it's just hamstring pain. Sciatica can stop at the knee, especially if they've already been going to therapy a while and it's starting to improve. If it goes, the main symptom of sciatica, though, is that it goes below the knee and it's towards the back of the leg. A herniated disc can cause sciatica, but it could also be caused by just tightness, postural deviations, and specifically tightness in the piriformis. The sciatic nerve travels, the piriformis is kind of like this. It travels either above, below, or pierces right through the piriformis to go down the leg. So if it's tight, it will put pressure on the sciatic nerve. So piriformis stretch is great for anybody with radiating pain down their leg. But the main goal is to centralize the pain. So this picture below shows the pain centralizing. As it goes towards the right, the pain is getting less and less down the leg and more localized or centralized to the area of ailment, the area that is actually damaged itself. If it peripheralizes, that means it's actually getting worse down the leg. It's going further down the leg. That tells you that your treatment is not working. If the pain peripheralizes, you need to stop and try a different treatment. So, with the repeated extension we talked about with a herniated disc, if a patient is doing that and they're like, oh, my back is actually hurting worse, but their pain centralized, because sometimes as it centralizes, it gets more intense in the low back, but goes less down the leg. That's actually a desired response. That tells you the treatment was effective. So you'll just have to educate the patient on that and say, even if the pain, it gets just a little more intense in the back, if it's bringing the pain out of the leg, that tells you we're working in the right direction. If you start to feel more pain going down the leg with any exercise, stop. Let me know. If you're doing it in a home exercise program, don't do it again. Come back and tell me at your next treatment so we can change it and make it the right exercise for you. A change in lifestyle might be required. Remember the ergonomics, maybe their job, maybe their chair or their bed, or their sleeping position. Things like that can cause worsening low back pain. One general rule of thumb is we never mobilize a hypermobile segment. And so if somebody already moves too much in an area, then we do not want to make it move more. And traction is included in that. So if there's an area of the spine that's unstable and it's just moving more than the normal, significantly more, then you do not want to mobilize it in any way, including traction, because what you could do is actually push it too far out of place, and it could start pushing on the spinal cord, which would then be a medical emergency. We don't want that in any case. Instability is often a issue of weakness. So if there is an area that's hypermobile, it's moving too much, then you will often find that the transverse abdominis is weak, which we know is common with people with back pain in general. So it's always a good idea to test that out and strengthen it. Another thing with that, with the instability, is that some people, we will look at this in lab. I want to make sure. So as you're doing a prone press up, you want to look and see that every segment along the spine is moving kind of fluidly. So it's like a fluid curve. What you'll sometimes see is that it just hinges. There's one area that all the movement is coming at and everything else is stiff. And that is not the ideal. So we'll talk later about doing different mobilizations to loosen up some of the stiff areas, and you want to try and keep from that happening, because then that area that the hinge is occurring becomes hypermobile. And then remember to look for triggers that initiate the chronic inflammation and change those if possible. One reason I have this picture is when I was in school, we did the South Georgia Farm Workers Project. One of the biggest issues was low back pain. The problem was they were required to do a lot of labor in a certain amount of time and all this. And what they would do is often pick corn, was specifically the main areas we were going, were cornfields. They would pick it and toss it and pick it and toss it. And they were always doing that exact same movement to the same side all day, 12 hours a day, day after day. And what we suggested was just every hour switch to the other side of, there was like a big piece of equipment that they were throwing the corn into. If everybody could switch sides so that for 1 hour you're going to the right and the next hour you're going to the left. But not everybody, was willing to do that. So if there is a way you can say, okay, you're working a factory job where you're doing the same type of task over and over, is there a way that you can change your position on the line? So instead of doing it with your right hand every time, you can switch and do it with left. Or if there's anything you can do to change the provoking factor, make sure that you do that. Okay, so we talked about a lumbar cervical, or a lumbar herniated disc, and now we're going to talk about the cervical herniated disc. So same problem, but now it's in the cervical spine rather than the low back. Now it's really rare to get a herniated disc in the thoracic spine, because the thoracic spine is typically hypomobile, so it kind of stays in more of a fixed position than the other two, and so it's more rare. Usually if there is one, it's more of a traumatic injury versus like overuse, and a lot of your thoracic spine pain is actually referred pain. So I would keep that in mind, that typically if somebody is complaining of pain in their mid-back and their thoracic spine, you would look at their posture, because it could just be coming from weak postural muscles, poor posture. With women, it may be that they have heavy, large breasts up front that are kind of pulling on them. It could be the way somebody's made. But otherwise, if you cannot find a cause like that, oftentimes it is referred pain from an organ, specifically the stomach. Could also be, I believe, the liver. So ruling out, and one way you rule that out is you ask them, okay, is there a position that provokes it? Is there a position that relieves your pain? Does it get worse when you lay down at night? Does it get worse after meals? And if they do not have a position of comfort or a provoking position, either one, and they do have other symptoms like worse at night, worse or somewhere around mealtime while they're hungry or right after they eat, if there's any fever involved, chills, night sweats, systematic responses, that all tells you it's probably not musculoskeletal. There's probably something else going on. And I have caught stomach infection before that was causing the patient to have thoracic back pain, and I just sent her back to the medical doctor, and he put her on antibiotic, and she was good. So you do want to catch that if that's the case. But when it's cervical, I digress. when it's cervical, you can do basically the same types of things with the low back. You can do traction, but now you're doing it to the cervical spine. Manual therapy, again, you're loosening up any restrictions and tight areas, trigger points. Postural retraining, trying to get the area opened up, so pec stretches and getting the head upright, not leaning down. With the stretches, oftentimes with the cervical spine, what people will do is they start to hunch their back and their head's looking down in order to be upright with society. Then they do some upper cervical extension. That's called forward head posture. So they're bent down and their head's looking at the ground, which is lower cervical flexion. And then they have to look up, which is basically the top two vertebrae extending. So it's upper cervical extension and lower cervical flexion, and that's called forward head posture. So actually stretching the suboccipitals at the very top of the cervical spine, and then stretching the flexor muscles lower. So that would be a chin tuck. That's going to be the best exercise for you. So chin tuck, you kind of go back and give yourself a double chin. This is a progression to go against gravity. That would be a prone chin tuck to go against gravity. Most time, I don't get a lot of people to that point. But what I do notice is a lot of people do like this. Instead of going straight back, they just kind of nod their head up and look up. And if you're cueing them and you're telling them and they just can't get it, you could have them stand against the wall and say, okay, now pull your head straight back until it touches the wall. Or in a supine position, I also find that a lot more helpful. Okay, you're laying flat on the bed. Now push your head, the back of your head, straight into the table. But remember, if they are in a supine position, then the position or the movement is gravity assisted. Gravity is kind of helping them with that movement. So that would be the easiest progression. Standing would be next. Prone would be the hardest. And then again, ergonomic education. So here's a little figure over here that's reminding you of some of the things that we look for when we do an ergonomic assessment. The height of a computer screen versus the patient's eye level. The arms rested down towards their side, the elbows bent at around 90 degrees, the wrist in more of a neutral position, the feet flat on the floor, or even better would be at some type of an incline, but you certainly don't want them dangling, or you don't want the chair so low that your knees are above your hips. They need to be in line with the hips. Lumbar support is important. And all of these things are what we recommend for someone who has a job that they're sitting a lot, which, you know, even if you're not at your job, most of the time we sit a lot in general. Okay, so the next thing we will go to is the anterior cervical, I bet I changed the order. Yeah, I did. Anterior cervical discectomy and fusion. So this is a surgical approach to remove a damaged disc in order to relieve pressure on a nerve root or on the spinal cord itself. Anterior cervical discectomy and fusion. So like right here, if there was a severe disc bulge or herniation that was pushing into the spinal cord, what they would do is they would come in anterior because they come in through the front. So the scars will be oftentimes on the front of the neck. Sometimes they can go in at a different angle, but often they'll go in through the front of the neck, and they will remove whatever excess part of the disc. Sometimes they'll remove the whole disc, and then they fuse it together so that the bones aren't, if they remove the disc, well, that's the cushion between the bones. You remove it and it's just bone on bone. So and once they remove it, they fuse it at kind of a distracted height so that the bones aren't just laying on top of each other and grinding. They are separated slightly, and then they fuse it apart. This is typically indicated if the person has severe pain, numbness, tingling, or weakness going down one or both arms. The symptoms down the arm are called cervical radiculopathy. We'll get to that later. But if those symptoms are severe And especially if the numbness doesn't go away, never gets relieved, at that point they need to do something or the damage will become permanent. And then it's also known as a cervical decompression. Treatment is loosening any tight muscles that are adding pressure to the area. Of course, manual therapy to loosen those, stretches to loosen those. Back to our postural training, those chin tucks, reverse shoulder rolls, pulling your shoulders down, pec stretch, opening up the chest, and then upper extremity strengthening. So if they do have weakness involved, then you're going to want to strengthen to get back to normal. It is recommended that you avoid cervical traction for the first year of healing after a surgery. So because there's a fusion there, you don't want to be pulling on that site and maybe loosen some of the area. The next two slides are things we will go over in lab. Your scalene stretch, your middle scalene, you lean straight to the side. Anterior, you kind of look over the opposite shoulder. And posterior, you basically smell your armpit. Those are the three scalene stretches, and we will practice those in lab together. Manual therapy to the cervical spine. STM stands for soft tissue massage, DTM, deep tissue massage, MFR, myofascial release. All of those things we're going to practice in lab. Practice palpating, finding each of these muscles, and then doing the manual therapy on those. Okay, so compression fracture is what we will be going to next. Okay, so the compression fracture that is related to osteoporosis due to or secondary to is this abbreviation. With someone who has compression fracture of the spine, they do want to avoid flexion exercises. So I really wouldn't recommend repeated flexion like crunches for any low back patient, but especially for these. You do want to teach them some proper lifting techniques, proper ergonomics, how to move around so that they're not damaging. Oftentimes that's kind of what caused the compression fracture to begin with, was doing something with poor mechanics. And then eventually you want to get to a place where you're stretching all the things that are tight and pulling on the area, so as hip flexors, hamstrings, and then stabilizing the core, that transverse abdominis strengthening. With spondylolisthesis, so that is an anterior slippage of one vertebrae on the one below it. So spondylolisthesis, the vertebrae has slipped forward. Typically, it's associated also with spondylosis, because spondylosis, the pars interarticularis, or the portion that connects the vertebrae to the remaining parts of the spinal column, so the area where the body connects basically to the spinous process, breaks. There's a fracture there, which is called spondylosis, and if that happens, then it frees that area up to slip forward. So if that's connected, it can't slip forward. But if it is fractured, then it frees it up to slip forward and for spondylolisthesis to happen. You would use the flexion bias protocol. You need to be really careful with these patients, because if already it's slipped forward, then it's already putting some compression on the spine. Well, hopefully it's not, but it could easily slide into the space where the spinal cord is traveling. Even if it's slipped forward just a tiny bit, it may not yet be compressing the spinal cord, but if it slips even more, that's dangerous. We never want compression of the spinal cord. So using the flexion bias protocol, strengthening in kind of a neutral or a somewhat flex position, and again, strengthening the core stabilizers. He is doing one of the progressions of a transverse abdominis strengthening, so tightening that transverse abdominis and eventually doing what we call a knee fallout, where the knee goes very slowly to the side, and if you start to notice your hip falling to the side with it at all, your ASIS, then your transverse abdominis is not stabilizing, so come slowly back up. And you can do it on each side. Stretching of the hip flexors and the psoas again to keep, and even the quadratus lumborum to keep pressure off those areas. And one more term to know is stenosis. Stenosis is the narrowing of the spinal column. It could be from spondylolisthesis, but it could also be from tumors, from stenosis. Stenosis is what I'm talking about. There are several things that could cause spinal stenosis: severe arthritis, swelling, and anything that pushes in on the spinal cord would cause that. All right, ankylosing spondylitis. This is actually a rheumatic disorder, so it's caused by a systemic inflammatory process. It can cause inflammation, chronic inflammation of the spine, and then eventually that inflammation causes the spine to grow, the bone to, it causes more bone to be laid down in response to that chronic inflammation, and it becomes fused together. So it's ankylosing is the fusion of those portions, and some places call it bamboo spine because the spine becomes fused completely together, and so it's an immovable piece of bamboo. It's just one straight stick. And some of the other joints could also become fused like this. They may also have pain in their ligaments. Typically, this type of disorder would start actually early on, like in adolescence, and peak during their 20s. So it may be a child that you're educating on these things. But one of the main treatments is to educate them on the condition, on what's going to happen, on the prognosis and all that, and teaching them correct postures. So that as the spine begins to fuse, it fuses in more of an upright position than a flexed position. And the main way you do that is exaggerating the lordosis. So if you exaggerate the lordosis, then the kyphosis is still going to be in a flexed position. That's what kyphosis is. But if you exaggerate the lordosis, then that can at least counteract some of that kyphosis. Otherwise, the spine becomes fully flexed. So some of the ways they do that is by every time they sit, they need lumbar support. When they sleep, encourage sleeping in prone. Some people just can't do it. I'm one of those. But encourage sleeping in a prone position so that they maintain an erect spine and maintain that lordosis. But if they're sleeping flexed and sitting flexed and all that, they will absolutely be stuck in a flexed position. So educate, educate, educate. Trunk and scapular stabilization, again, the transverse abdominis, but with the scaps, you are doing more of like a plank type position. Oftentimes I'll start against the wall, and then you can start them out with a plank and then drop a hand and make sure the shoulder girdle stays straight. Otherwise, if it starts to cave in, then the shoulder is not stabilizing. And we'll go over some scapular stabilization exercises in lab as well. Range of motion and stretching to maintain hip flexion or hip extension, because typically they go towards that flex position. So to try and maintain that movement, and then also to maintain shoulder flexion range of motion. And the reason being is just to increase function. So although they're in a flex position, if they are kind of down like that, they're going to need to be able to reach up high to grab things. We need to reach up high anyways, but especially if your body's already flexed over. So maintaining that range of motion and stretching those joints is key in the treatment of this condition. All right, rib subluxation. We will teach this technique in lab, how to properly help a rib that has become subluxed. A side joint dysfunction, we will also talk about how to assess and determine if someone has it, as well as how to treat it with muscle energy techniques in lab. tension headaches. So that is caused, if it is a true tension headache, that just means the headache is coming from tight muscles. Typically, the tight muscles are coming from postural deficits. They're standing, sitting, hunched over, or working out in a poor posture, or whatever they're doing, sleeping wrong. They're doing something to cause the muscles to tighten up. And once those muscles tighten up, it puts extra pressure and causes headaches. So the main thing that we want to focus treatment on is loosening up the tight muscles. Now, one of the main muscles that happens to be tight is the suboccipitals. Remember, I talked about forward head posture. Those suboccipitals are constantly pulling the head to keep it in an upright position. So even if you're hunched down doing some typing and you're constantly doing that, that's going to get tight as well. So here is a suboccipital release, where the therapist is placing their fingers right on the suboccipitals and holding. Ideally, you would maintain that pressure until the suboccipitals begin to loosen up under your hands. You can kind of feel them loosening often. And we will practice that in lab. The other is a self-mobilization, where they can place a roll. It would be better to do something hard like the patient is doing, not super hard, but not a towel roll. It wouldn't probably provide enough pressure to do much. So something somewhat firm needs to be placed right under the suboccipitals, and they lay in supine, and typically for about 5 minutes, hold that position to do kind of a self-mobilization suboccipital release. Now here is just a list of some exercises, stretches that somebody can do throughout the day, even sitting in their office chair, to kind of counteract some of this these postural deficits from that position. So having somebody move often, stretch throughout the day is good. Teaching them, stretching the pecs, stretching all the tight muscles, and teaching them to correct their posture often. And then working on cervical stabilizers. Again, one of the best exercises for that is the chin tuck, to work on those deep cervical stabilizers. Scapular stabilization, again, we will go over in lab. And stretching. Stretch whatever's tight. Often the sternocleidomastoid, upper trap, scalenes, levator scap, and suboccipitals. Those are the main ones that are tight, and we will practice palpating those as well as stretching and mobilizing those in lab. Cervical radiculopathy is neck pain. It can also be numbness, tingling that radiates down into one or both arms. So it starts in the neck and the symptoms go down the arm or both arms. Treatment, again, cervical traction. This is kind of a manual traction. This is another method of doing manual traction. This is a machine that a patient can buy. Typically they look a little different. The ones I've seen look a little less crazy than that one. But they can attach to a door frame and do their own cervical traction at home. This is another way of doing some type of a self-mobilization, where you kind of bring your hands right under the base of the skull and pull up to do some slight cervical traction. You really can't get good enough grip to maintain for a long duration and make a lot of effects, but if you did it frequently as part of your home exercise program, it may help maintain some of the gains that you're getting from the traction at the clinic. Neck stabilizing, posture training, and stretching are all key here too, and it's basically the same types of exercise that we've talked about with any of your other neck pain, as far as what to stretch and what to strengthen. All those exercises are similar for each of these conditions. Okay, so with cervical myelopathy, this is where we're talking about the compression on the spinal cord, and this one specifically is due to a degenerative condition. There's a lot of different things that can cause spinal cord compression, but this one in particular is talking about a degenerative condition. The main thing here is avoid extension. If already there's some pressure on, so see all the white here in this imaging. The darker color is the spinal cord. The white is the space around the spinal cord that should be there, and see right here in the cervical spine where that is almost non-existent. So it is getting pushed, the bone is pushing directly into the spinal cord. And if you do extension, when you're in extended position, the bones kind of close on each other and narrow the spinal column anyway. So if it's already too narrow and then you do something in an extended position, you're going to narrow it more and cause more damage. This will eventually cause some degeneration, this can be caused by degeneration, spondylosis, stenosis. Any of that could compress on the spinal cord. So typically symptoms are in both hands. It could also go down to the feet because remember, it's passing all the way down. So wherever it starts, you're going to have symptoms from that point and below. So it can be hands and feet, may have clumsiness, even some falls, bowel and bladder issues. So anytime there's compression of the spinal cord, it can cause bowel and bladder issues, maybe not feeling the need to go, maybe having urgency where you had no clue you had to go, and then all of a sudden you're running to the bathroom, having accidents that you're not able to control, all those. So loss of bowel or bladder control is a huge indicator that something is going on. And if it's a sudden thing, then it may be compression of the spinal cord, and that would be a medical emergency. They need to go immediately. And then gait instability. If you're not feeling your feet very well and you're becoming weak, you are going to be more likely to fall. You treat the condition that's causing it. You may or may not be able to actually change that condition. It may require a surgery, and the patient may or may not be trying to have the surgery. And if the surgery is performed too late in the process, the symptoms will be irreversible. So this is kind of an emergency. If they are having symptoms such as numbness that does not go away, then they need to go see a surgeon, because if they wait too long, then that numbness will never go away. And same with bowel and bladder function. If it suddenly disappears, they immediately need to leave wherever they are and go to the hospital, because that will become irreversible if they wait too long. And then the same type of treatment will be for this patient if they do have a surgery as with any of our other neck patients. So with posture exercises, stretching, strengthening if the arms are weak or legs are weak, and then functional or ADL training, trying to get them back to the highest function, even if there is some lasting damage. A laminectomy is one of the procedures that can be done to decompress the spinal cord. So if there is compression and extra pressure on the spinal cord, what they can do is they come in and basically remove the spinous processes and the portions of the bone that connect those to the remaining parts of the vertebrae. So they come in and they cut into that bone and remove it fully. They remove the lamina. Now this one shows that they did it on 3 levels, and that's pretty significant. They may only do it at 1 or 2, but it is a very intense surgery, and it is going to happen when it's kind of a intense situation. So if they're about to become paralyzed, then you definitely would want to go in and decompress. Again, it's a medical emergency. If there is any spinal cord compression, the surgery needs to be performed as soon as possible. If it's not performed soon enough, they may have continued symptoms. And with this surgical approach in particular, if they do have continued symptoms after the surgery, it's called post-laminectomy syndrome, where the same symptoms they went in for the surgery are still there. And the reason is the damage was permanent. It was done too late and the damage was permanent. So some of the things that we would do with a patient who has had this procedure would be teaching them how to maintain spinal precautions if they have precautions based on the surgical procedure, and where the surgery was performed, where on their body, neck, low back, anything. core stabilization, and eventually you would progress to your normal strengthening, postural training, stretching, functional mobility, but you would have to wait on clearance from the surgeon in order to progress through those. Okay, neck and back pain in general. So as you've seen, there's a lot of similarities on how you treat neck pain and back pain, even if the condition is caused by completely different things. So many patients actually come in without a true diagnosis. They come in with just neck pain as their diagnosis or back pain as their diagnosis. And some new therapists kind of get overwhelmed with that. Well, how do I treat if I don't even know what's wrong? Well, just like anything else, you stretch what's tight, you strengthen what's weak, especially core stabilizers almost always, whether it's neck or back. Core stabilization would be good. If it's neck, deep cervical stabilizers would be good. Do manual therapy to loosen up any areas that seem to be tight. Address the functional deficits if they're having trouble reaching overhead or walking or whatever, then you could add gait training or functional reaching, and then educating on the body mechanics and the proper ergonomics. Now, here are signs and symptoms that would tell you that something is bad, and the main thing we're worried about is compression of the spinal cord, and you would want to immediately refer them back to the medical doctor. Always discuss that with the supervising PT. Don't just like call an ambulance and she doesn't even know, or he doesn't even know that you've done it. I would definitely, even if you have to leave a treatment session and pull them out of one and say, hey, they're having these symptoms, thinking about calling the doctor. I wanted to make sure we're on the same page, or I'm thinking about calling an ambulance or sending them right now to the nearest hospital. I want to make sure that you're in agreement, and they may come in and do a quick assessment, or they may just say yes. But if they say no, there's further discussion that needs to be had quickly because the patient's health is on the line. If the patient has sudden changes in sensation, typically it's decreased sensation, but it could be tingling, burning sensation, sometimes even a hot or a cold. All those are symptoms of damage to the nerve. So if they have sudden bowel or bladder loss, so a recent change. Now, if it's somebody in their 90s and they haven't had bladder control in 20 years, I wouldn't just immediately call an ambulance on that. If it's somebody that's like, I had a patient tell me one time, I was asking specifically, you need to ask this specifically. Most of the time they won't tell you because they look at you as you're working on their muscles. So you're not somebody that needs to know about these personal details. So most of the time they will not come out and tell you. Of course, you're surprised some of the things people do tell you, but so I always ask specifically when I know they're having significant neck or low back pain. I will say, have you had any changes in your bowel or bladder function lately? Maybe PM more frequently, having accidents, constipated, not feeling an urge to pee or to poop. And if there's been a recent, obvious change, then I would send them to the hospital. If there's a severe stabbing pain or a severe headache, it could be an indication that this CSF, cerebrospinal fluid, has increased, the intracranial pressure has increased, or something is going on with the CNS. If there's changes in vision, speech, memory, personality, all those things tell you that something's going on with the central nervous system, and you don't play with that. And then if there's numbness that does not go away, they're saying, I did have this numbness that was coming and going throughout my arm, and I just noticed yesterday it's been numb for the last 24 hours. I would go back for another MRI. With TMJ dysfunction, that is limited motion, clicking, noises with movements of the jaw, and pain with movements of the jaw. So there's your jaw movements, the motion is limited, there's pain, there's clicking, sometimes popping. It could be due to trauma, somebody getting punched in the face or in a car wreck or something. Could be poor posture. Again, whenever you have that forward head posture, it puts a lot of tension on those neck muscles and the muscles that connect to the jaw and can cause TMJ. Could also be faulty movement patterns. I, for example, had braces because I had a tooth knocked out in a four-wheeling accident, and they just closed the gap up. And what it did was mess up the alignment of my bite, because now I'm missing a tooth and they just closed it. And so it kind of shifted my bite. And since then I've had some TMJ because everything's a little bit off kilter. And so things like that. If maybe their jaw naturally was kind of crooked, and then the orthodontist did procedures, braces and different things to straighten it back up, it may also still cause an imbalance at the jaw. Muscle imbalances will also affect TMJ. Often they complain of headaches and neck pain. And the treatment will include manual therapy and stretches to loosen up the tight areas, postural training to kind of avoid the things that are provoking the symptoms, treating the muscle imbalance, and then you can use some modalities. Ultrasound is one common one. Heat can also be used. I will say, if you're somebody that's going to do much work with TMJ, I do think that it would be ideal to get continuing education on it. There are courses on treating TMJ problems, and I definitely would recommend those before going out on a limb and doing a lot. Of course, if there's nobody else and you have to, then do what you can, but ideally you would have extra training to appropriately treat TMJ. So these are the different massage techniques and manual therapy techniques that we covered some last semester, and we are going to go back over these in lab. So make sure you're ready to work on each other and get worked on because we will go over all these in lab together. We will go over the piriformis release, the psoas release, hamstring rolfing, trying to loosen up a tight hamstring, quadratus lumborum release. We will also do this as a self-mobilization here for that. And then self-stretching techniques. So all of those we will go over together in lab. The facet joints, so those are the joints that connect one vertebrae to the one above and below it. Those are facet joints. So if this is my vertebrae, this now is the spinous process. These are the facet joints on the side. The middle portion that sticks in the very back right here is the spinous process, and the joints on the side right there are the facet joints. And so they'll connect with each other, and at each level of the spine they are altered slightly, so they have different degrees that they are slanted in order to connect to each other. So we'll look at this on the skeleton in class together, but the cervical spine connects at about a 45-degree angle, and then the thoracic spine is a 60-degree angle, and by the time you get to the lumbar spine, there is a 90-degree angle, so that they are connected to. They're kind of stuck forward and back, versus in the cervical spine, they're laying on top of each other at a slant. So cervical, thoracic, and then lumbar. And that is how the joints connect to one another. Okay, so the remaining slides will be covered in lab. So we will talk about glides. We will talk about how to do central PAs and unilateral PAs. Our body mechanics and ergonomics we'll go over, and we'll go over taping procedures, and then the remaining are case studies. So again, thank you for sticking with me through the lecture. I hope that you got a lot out of it, and I will cover the remaining portions in lab.